Hi, good morning. I'm here to give you a report over Mrs. Edna Edible. I hope you had a good night rest. So she's a 60-year-old female patient. She was admitted on 10/26. Her initial diagnosis was that she had anemia and hemotypoesis. Initially, she experienced some gastric pain while eating. Some of her past histories were hypertension, hyperlipidemia. She's full cold. She's not allergic to anything. She has a 22 gauge left hand on the left hand. I'm sorry. Her vital signs were with the normal ranges. She's on a clear liquid diet. She's on 94 2-liter nasal cannula. Patient is post procedure for a esophageal tear. She is maintaining well. She's a lower oriented ×4, but a little bit drowsy. Upon assessment back from the PACU, she was sitting up in her bed. And her lungs were, as when I assisted her lungs, they were normal and clear. Her bowel sounds are a little hypoactive, but they're starting to return slowly. Her upper abdominal dressing is dry and intact. I also made sure that her skin is cool and dry. She denies any pain. She had labs from hemoglobin and hematocrit on 10/26, but right now all her labs are normal. She also received 4 additional units of blood while in surgery. So I would just monitor her, her iron levels and her hemoglobin and hematocrit just to be, safe. She had a GI consult placed. And then I would recommend to continually just assess for any pain or complications post surgery. Look at her abdominal dressing. I would also, that hypoactive bowel sounds kind of did worry me because I didn't want her to get constipated. So I would just review the MAR if she has any stool softeners, and see if we could give her that, and if not, put a order in. She's also drowsy, so I would just recommend to just round on her, make sure that she's not getting up in bed without ambulating, and also make sure that the bed is locked, but just double check. Also, she has yellow socks, so I would just recommend to just make sure, teach her about wearing not taking the yellow socks off. And then I think, also, reinforce that, she can't have, she's NPO status. So, just make sure that, she understands that, I know that she might be hungry or she might want something to eat, but for now, just tell her that she can't have that. And then I have the UAP is very helpful with ambulating her to the church to the restroom, and she also bathes her, so you don't really have to worry about that, unless I don't know how staffing is. But yeah, I think that's pretty much it for Miss Edna Edible. Do you have any questions?
The patient's name is Tommy Toon. He's a 34-year-old male, full code. He is currently being treated for a sickle cell crisis. He was admitted on the 9th of November. He came in reporting shortness of breath and severe shoulder and joint pain. His hands and feet were swollen, and he had been experiencing headaches, fatigue, as well as abdominal pain. The patient also reports chest discomfort with exertion. He has not urinated in 24 hours and has not been able to eat very well in the past 2 days and has drank very few fluids. He has a past medical history of sickle cell anemia, stroke, hypertension, and coronary artery disease. His vitals are currently stable. He has an 18 gauge running in his right hand with D5 1.5 normal saline at 75 cc's an hour. He has no known drug allergies. He's currently on hydroxyurea, 15 milligrams per kilogram a day, Motrin, 400 milligrams Q6 hours for pain, and morphine, 4 milligrams Q4 hours for severe pain, as well as folic acid 1,000 mics a day, diastolic 20 milligrams a day, and atorvastatin 40 milligrams a day. He has no history of drugs, alcohol, or tobacco use. His vitals are currently stable, but he is on 2 liters of oxygen via nasal cannula, as well as on a renal diet. He is on bed rest with bathroom privileges. The patient is alert and oriented ×4, but he is still reporting headaches and fatigue. The patient still reporting shoulder and joint pain, and his hands and feet are still pretty swollen. PT is coming in soon to assess mobility and range of motion. The patient has not been able to urinate still, and does not currently have a catheter in place, nor is on dialysis. He still isn't eating very well and drinking very few fluids. He's still reporting abdominal pain as well as shortness of breath when he gets up, and chest discomfort when he gets up to go to the bathroom. The patient is married. His wife comes and visits him every day, so she should be by later today. The labs for him, he has an elevated white blood cell count at 18,000. His hemoglobin and hematocrit are both low. His hemoglobin is 6.8 and his hematocrit is 22.7. His potassium is 6. His BUN is 32, creatinine 4.7, and his GFR is 15, which means he's most likely in kidney failure. His liver enzymes are slightly elevated, and he did have cardiac enzyme tests, but they all resulted normal. There are orders for PT to come by, as well as a typing cross for 2 units of packed RBCs with a re-pH and H 2 hours after the last unit has completed, as well as an ultrasound of the kidneys. My recommendations would be a bladder scan and possibly a straight cath to help remove any urine in the bladder, which could help relieve some discomfort in that abdominal pain he's experiencing. I'd also recommend an order for maybe a diuretic or something to help lower that potassium. And I would also recommend the patient refrain from large amounts of caffeine or coffee with his breakfast. That may cause decreased tissue perfusion peripherally and cause sludging of sickle cells.
Hello, my patient is Mr. Macho Man. He is a 65-year-old male. He has recently been widowed, and he came in with complaints of productive cough for 2 weeks with yellow sputum, mild dyspnea, pain with deep inspiration in his chest and back, fever of 101 for 2 days that initially responded well to Tylenol and oral fluids. The patient has a history of hypertension, hyperlipidemia, arthritis, bronchitis, GERD, and depression. The patient has no known drug allergies and is a full code. His current medications are Tylenol as needed, ibuprofen as needed, Livaquin 500 mg twice a day every 12 hours. The first dose was last night at 21,000. The patient usually smokes 4 to 6 cigars every day, but has stopped smoking 1 week ago after the dyspnea got really bad. The patient is a casual drinker and denies any illicit drug use. The patient is on oxygen 93 with 2 liters nasal cannula. The patient's oxygen saturation goes down to 90% on room air. He is on a regular diet and is on bed rest with bathroom privileges. The patient is alert and oriented ×4. The patient has a fever that fluctuates from 100.6 to 103.4. The patient's skin is warm to touch. and he eats 50% of his meals. The patient is having a hard time finishing meals due to pain from inspiration. And even though he has a history of depression, he has shown no signs of suicide and is cooperative. The patient's labs are white blood count 11.8. He has elevated lymphocytes, basophils, and eosinophils. The physician's orders are a repeated chest x-ray, a new CBC, and a sputum culture to check if the Levaquin is working. If the patient can't produce sputum, then call RT to come get the sputum. And also an order for Levaquin 500 mg twice a day every 12 hours. It is recommended to promote adequate rest and reduce stimuli to help the patient relax. Also, increase the patient's O2 on his NC, nasal cannula, to 4 liters to raise O2 saturation to at least 95%. Cough medicine may also be helpful to block the cough reflex. It may thin and loosen mucus, making it easier to clear from the airways. The patient is suspected to have a diagnosis of bronchitis. Do you have any questions or concerns for me?
Hi, good morning. I hope you had a good is it morning? I'm sorry. Good afternoon. I hope you had a good rest. So my patient was Dee Driscoll. Ms. Driscoll is 46-year-old female patient. She was admitted to the ER 2 days ago. She was walking on a treadmill as usual, but she started to experience some chest pain that radiates to her back. She took a nitroglycerin 10 minutes. Later, it didn't work, so her husband called 911. She was diaphoretic, nauseated, pale, and dizzy. Her past history was unstable angina, hypertension, hyperlipidemia. The medication she is right now is she's on Plavix. The physician has her on Plavix and lisinopril and the statins. So normally all these correlate again with her chest pain. She denies smoking. She says she drinks occasionally. Her IV is 2AC 16 gauge. On the left, she has a healthy healthy diet. Her vital signs are within normal range. They're all stable. So she was diaphoretic and nauseated and dizzy. She felt faint, so they did an EKG on her, and it showed ST segment elevation and lateral leads with flipped T wave. They did lab results, and they were all negative. The cardiac enzymes were negative. So fluids were given to her as well. So when she arrived to the ER, she was taken to the cath lab, and her initial cardiac images showed circumference of 85% occluded at mid-vessel, and diagonal was 75% occluded. That's pretty, bad. So obviously they placed a stent on her to open both arteries with a TIMI 3 flow showing lumen 80% open. Again, her vitals are normal. Medications were given. And then she had to stent place. So, just be cautious about it. I normally tell her if she's having any pain. She says she's not having any pain as for now. There's no labs or imaging pending. There's the physician ordered a CBC CMP with fasting hyperlipidemia. So for me, I would honestly, after her care, I would just educate her about her new lifestyle, about the stent. She's kind of anxious. It's a new process for her to manage, so just for her to accept it and reinforce the healthy heart diet. She doesn't experience any chest pain. She's very anxious about like her death feeling. So just educate her that that was a normal symptom because of her occluded artery, just to calm her anxiety. We also want to educate her on her angioceal. And also, you know, just be alert that you know, she is a high risk patient for fall risk. So she does have yellow socks on, and she knows I told her that she could call me or the UAP assistant if she needs help ambulating or if she needs anything. And then for her breakfast tray, I told her that she could have you know, anything from the Hearty Heart diet on the menu. But again, if she needs help, you know, I told her she could give a call to the nurse. So yeah, I think that's everything for her. If you have any questions, do you have any questions? No? Okay. I hope you have a good day.